Hello, everyone, and welcome. Today, we're going to tackle a topic that can be really confusing, but is so important for long term health: subclinical hyperthyroidism. We'll be walking through the European Thyroid Association guidelines from 2015 to figure out what this condition is, why you should care about it, and what the experts say we should do. So let's jump right in. So picture this. You've just had your regular blood test done, right? And your doctor calls and says, listen, your thyroid stimulating hormone, your TSH, is a bit low. But the thing is, you feel totally fine. No symptoms, nothing. You're probably thinking, now what? This very common and very puzzling situation is exactly what subclinical hyperthyroidism is all about.
You can think of it like a warning light on your car's dashboard. You know the one? The engine sounds perfectly okay, everything seems to be running smoothly, but there's this little, just sitting there. It's a silent alarm. And the big question is, do we need to pull over and check under the hood, or can we just keep driving?
All right, so what is this thing officially? Well, subclinical hyperthyroidism is what we call a biochemical diagnosis. Now, this is a really crucial point. It's not about how you feel. It's defined purely by your lab results. It means your TSH is below normal, but your actual thyroid hormones, your T3 and T4, are still chugging along within the normal range. It's a diagnosis based on numbers, not symptoms.
But here's where it gets a little more detailed. It turns out not all subclinical hyperthyroidism is created equal. The guidelines split it into two grades. Think of it like a scale of severity. Grade 1 is when your TSH is low but still detectable, somewhere between 0.1 and 0.39. But then you have grade 2. Here, the TSH isn't just low, it's suppressed. It's so low that often the lab equipment can't even find it. And trust me, this difference between grade 1 and grade 2 is absolutely key to everything that follows.
So, who are the usual suspects causing this silent alarm to go off? Well, it's typically an underlying thyroid issue. It could be Graves' disease, which is an autoimmune condition. Or it might be thyroid nodules that have basically gone rogue and started overproducing hormones all on their own. Doctors call these autonomously functioning nodules. Right. So you might be thinking, okay, if it's subclinical and I feel fine, why is this such a big deal? And that is a perfectly fair question. But this is where we get into the real heart of the matter, the hidden, long-term risks that can lurk beneath the surface.
Honestly, this is the million-dollar question for everyone involved. What happens if we just ignore that low TSH and carry on with our lives? Well, the evidence we have points to some pretty serious potential consequences down the road. The guidelines point to three main areas of concern, especially if you have that more severe grade 2 condition. First, there's the risk that it will stop being subclinical and become full-blown symptomatic hyperthyroidism. Second, and this is a big one, are complications for your heart. And third, something you might not expect, a higher risk to your bones. Let's dig into each of these. First up, the risk of progression. How likely is it that this silent condition starts to, shout? If you have grade 1, the chances are actually pretty low. But with grade 2, it is a completely different story. We are talking about a 5 to 8% chance every single year. You can see how that adds up over time, right? The likelihood becomes very real. Now let's talk about the heart. This is where things get really, really serious. Even if you don't feel a thing, a suppressed TSH puts a constant, low-level strain on your heart. For people with grade 2, the risk of developing atrial fibrillation, a very dangerous type of irregular heartbeat, is more than 2.5 times higher. That's a staggering number. And it doesn't end there. The risk of having a heart failure event is nearly doubled for people with grade 2. It's a powerful reminder of how a seemingly small abnormality on a lab report can have a massive impact on one of your body's most vital organs. The risks just continue to stack up. Grade 2 is also tied to a higher risk of death from coronary heart disease. And then there's the surprising connection to your bones. This condition can actually accelerate bone loss, which means a much higher risk of fractures, especially of the hip and spine. Okay, so we've established that the risks are very real. The next logical question, of course, is what do we do about it? This brings us to the decision-making part. Let's look at the framework doctors use to decide whether to treat or to simply watch and wait. This little table sums up the core recommendations beautifully. As you can see, the decision really hinges on two main things: your age and the severity or grade of your condition. Notice the bold text. For anyone over 65 with grade 2, treatment is strongly recommended. For everyone else, it's a bit more nuanced. So,
let's unpack the logic behind this chart. Why treat an older person with the severe kind, but maybe not a younger person with the milder version? It all comes down to a very careful balancing act, weighing those risks we just talked about against the potential benefits of treatment. Let's start with the clearest case. If you're over 65 with a suppressed TSH, that's grade 2, the evidence is strong and the guidelines are firm. Treatment is recommended. Why? Because the potential for very serious outcomes like heart failure and fractures is just too high to ignore. Treatment here is all about prevention. Now, what about an older patient with the milder grade 1 condition? Here the recommendation is to consider treatment. The main worry is still the heart, specifically that increased risk of atrial fibrillation. So if a patient already has some kind of heart disease, the scales tip much more towards treating. Okay, what about younger folks under 65 with the more severe grade 2? Here, treatment is suggested, particularly if they're having symptoms or have other health problems. A big reason for this is that high risk of it progressing into full-blown hyperthyroidism that we mentioned earlier. And finally, we have the lowest risk group, young, asymptomatic people with grade 1. Here, the guidelines are just as clear. Treatment is not recommended. The risk of progression is low, the evidence for long-term harm is weaker, and the potential side effects of treatment just aren't justified. The best approach is what we call active observation.
So, what does active observation actually look like in practice? Well, it's not about ignoring the problem. It's a structured plan. First, you'll repeat the thyroid tests in a few months to make sure the low TSH is persistent. If it is, you'll get regular blood tests every 6 to 12 months, and you and your doctor will keep a close eye out for any new symptoms or changes.
This quote from the guidelines really gets to the very heart of the dilemma. They're basically saying, look, we don't have perfect, large-scale studies proving that treatment prevents every single bad outcome. But what they do have is a mountain of evidence that shows untreated SH, hyper, especially grade 2, is associated with serious, potentially life-threatening risks. So the decision to treat is based on managing that very well-known risk.
We've covered a whole lot of ground, haven't we? From diagnosis to the risks to the complex decisions around treatment. The point is to give you the knowledge to have a really informed conversation with your doctor. So we'll leave you with one final question to think about. Knowing what you know now about your age, your TSH grade, and your health, what's the most important question you're going to ask?